Good afternoon, everyone. Welcome to the first of a four-part Medicare Bootcamp series. This convenient and educational session is hosted by Region 10 chapters of HFMA. The topic for today's session is Medicare 101, and we are scheduled to run 90 minutes for today's session. I would like to welcome our guest presenters for today's boot camp. We have Bragg Hemme as well as Sarah Iams. Bragg is a shareholder at Pulcinelli PC, and in order to help healthcare clients address their targeted business concerns, Bragg draws on a wealth of practical experience and a solid understanding of the industry gained during her time as both external and internal counsel. Her experience includes advising clients regarding the complex and ever-changing federal and state regulatory environment, including Medicare, Medicare Advantage, Medicaid reimbursement, enrollment, licensure, and certification issues, regulatory compliance, and fraud and abuse. Sarah is also with Pulcinelli PC. She collaborates with clients and colleagues to navigate the complex healthcare regulatory environment. She regularly counsels clients on Medicare and Medicaid reimbursement, enrollment, fraud and abuse, and other regulatory compliance matters. So without further delay, I'll hand the call over to today's guest presenters. Bragg and Sarah, please go ahead.
Thank you, Nikki, and welcome everyone. So today's Medicare 101, this is an intro to the various payment models under the Medicare program, the structure of the Medicare program. Our intent is to give a high-level view of Medicare structure and how the various parts of Medicare work together. There are four parts that we'll go over, A through D today. Probably spending a bit more time on Parts A, which is inpatient hospital, SNF, and the like, and Part B, which is outpatient physicians and payment models for other practitioners and suppliers. But we will also touch on Medicare Part C and D and give some information about some other payment models that are on the horizon for CMS. And certainly if you have any questions, let us know. But as I said, this is sort of a high-level summary. We could talk for days on lots of these issues. And with that, I will turn it over to Sarah to talk about the structure of the program.
Thanks, Bragg. Yep, we are going to start by talking about the high-level structure of the Medicare program. The program and the benefits in particular are structured in four distinct parts, and they're most commonly referred to as Parts A, B, C, and D. And those are labels that aren't exactly helpful if you're trying to understand what's covered in the Medicare program. But we're going to go into a lot of detail about each part as we go through the presentation. But just at a high level, Part A covers hospital inpatient stays, skilled nursing facilities, stays, most home health benefits. There are some Part B home health benefits, hospice care, and this accounts for roughly 29% of benefit spending, or did in 2016. And for most beneficiaries, there is no Part A monthly premium. Most people are entitled to what's called premium-free Part A by having paid into Social Security for a certain period of time. But the Part A benefits are subject to a deductible and co-insurance amounts. Part B at a high level covers physician visits, outpatient hospital services, durable medical equipment, also referred to as DME, some drugs, diagnostic services, and a number of other things. We're going to go into a lot of detail about that. Part B accounted for about 26% of the benefit spending in 2016, so just a few percentage points less than Part A there. Part B benefits are subject to a monthly premium for beneficiaries and a deductible every year, and cost sharing for individual services as well. Part C is also commonly known as the Medicare Advantage program, and this is a program through which the beneficiaries enroll in a private health plan. So, much like an HMO or PPO plan that you might have through your employer, that's a Medicare Advantage plan operates in a similar way. And the beneficiaries receive all Medicare covered benefits through that private plan. So the Medicare Advantage plan is essentially a replacement for Parts A and B, or what's called original Medicare. Sometimes Part A and B are referred to as original Medicare. So they're not, if you're enrolled in a Medicare Advantage plan or in Part C, you're not also enrolled in A and B. In 2016, the payments to Medicare Advantage plans accounted for about 29% of overall Medicare spending. Finally, we have Part D, which is the voluntary outpatient prescription drug benefit. Like Medicare Advantage, the Part D benefit is offered through private health plans that contract with Medicare. But unlike Medicare Advantage, the Part D benefit is in addition to Parts A and B. And these are sometimes the prescription drug plans can be offered either as standalone drug plans that you would have in addition to Part A and B, or they can be coupled with a Medicare Advantage plan and what's called an MAPD plan. And in 2016, Part D accounted for 16% of benefit spending, so it's a substantial program itself. So the Medicare parts that we just discussed, provide the framework for describing Medicare covered benefits, but more generally, if we're trying to understand how the system works as a whole and how providers and suppliers ultimately get paid, one way to think about it is in terms of these 4 basic requirements. And we put basic in quotes here because, as you'll see and as we get into the weeds on any of these issues, it's not exactly simple. But the requirements in general to get paid are that you have an eligible and entitled Medicare beneficiary, a properly enrolled provider or supplier. If the provider or supplier has to enroll in Medicare, a covered service, so it has to be covered under Part A, B, C, or D, and the provider or supplier has to meet all of the Medicare payment conditions and coverage conditions. So those are the main requirements. In case you're a visual learner, this is kind of how we chose to represent it here. You have to have each of these 4 components to ultimately get to the money at the end of the trail here. The first piece of this is, a relatively obvious one. For Medicare to pay for an item or service, the person who's receiving that item or service has to be eligible and entitled as a Medicare beneficiary. So who qualifies? First, a person becomes eligible when they turn 65. This is probably the criteria that everyone's most familiar with, and you probably hear people talk about increasing the eligibility age from time to time. In Washington, the politicians talk about increasing it when they're discussing the long-term viability of the program. That hasn't happened yet, so for now we're still at 65. You can also, though, become eligible if you're diagnosed with ESRD, or end-stage renal disease. And the last criteria here is that you have a disability and you're disabled for at least 24 consecutive months. So you'll notice that we've used both the terms eligible and entitled here. Those terms are often used interchangeably, but it's important to note that they have distinct meanings for Medicare purposes. And that's just because a beneficiary can be eligible, meaning they fall within one of these categories, but they may not yet be entitled, either because they've yet to enroll. Most people are automatically enrolled, but some do have to actively enroll, or because they're subject to, may not be entitled because they're subject to a waiting period. And that, one example of that is ESRD beneficiaries who are subject to a 3-month waiting period in most instances. So in most cases, people who are eligible are also entitled or about to become entitled, but just be aware of that distinction. If the person happens to be eligible but not entitled, then Medicare won't pay for that service. The next requirement is that for Medicare payment is that you have an enrolled provider or supplier. These are also 2 distinct terms, provider and supplier. People often, you probably most often hear people use the term healthcare provider, and that's sort of a generic term that we use to describe a lot of different types of healthcare entities, but Medicare does define them uniquely for purposes of enrollment and payment in the Medicare program. A provider is defined by statute as an institutional healthcare facility, so that includes things like hospitals, skilled nursing facilities or SNFs, and home health agencies, hospice, and there's a whole list of them in the statute. A supplier, on the other hand, is basically everything other than a provider. It includes a lot of different types of non-institutional entities, so physicians, individual practitioners, physician groups, ESRD facilities, DME suppliers, IDTFs, independent diagnostic testing facilities, labs. The list of suppliers also goes on. And the reason for the definitions matter in this context is that some statutory and regulatory requirements apply only to quote-unquote providers, not suppliers. So that's another thing to be aware of if you're ever looking at the Medicare rules and trying to figure out if something applies to the situation that you're dealing with. So what are the enrollment requirements for providers and suppliers? We're not going to go into all of the details here because we'd definitely be here all day if we tried to go into every single enrollment requirement for every single type of provider or supplier, but the general requirements are that providers and suppliers have to submit an application. In most cases, providers submit the CMS, called the CMS Form 855A. Suppliers also submit enrollment forms that they have a number of different ones. It can be either the 855B, that's probably the most common, or 855I, which is for individuals. And they also have the 855S, which is typically for DME suppliers. There are exceptions to this, division. So, for example, ESRD facilities enroll using the 855A, which is typically for providers, but they are classified as suppliers for all other purposes. Providers also have to enter into provider agreements with CMS, certifying that they will follow all the rules, basically. The agreement outlines a number of requirements that are specific to providers rather than suppliers, related to how they provide and bill for services. Some suppliers do enter into what's referred to as a participating supplier agreement, but that's a distinct agreement from this, what you commonly hear as the provider agreement. And finally, providers and suppliers, and so, I guess some types of suppliers have to go through a survey and certification process. They have to meet, when they have to go through the survey and certification process, they have to meet what are called Medicare conditions of participation, sometimes called conditions for coverage, although that's sort of a confusing term. You can probably more easily categorize these as enrollment requirements. And CMS typically contracts with state agencies to conduct these surveys and to measure compliance with all of the various conditions. Sometimes the surveys are done by third parties. You may be familiar with the Joint Commission, does a lot of surveys for hospitals. And these requirements are not typically service specific, so they don't relate to a very specific type of service that a patient received, but more so general operations of the provider or supplier. They involve things like, what are the qualifications of the personnel, what, physical facility requirements do you have? So what does your space have to look like, and how does it have to be outfitted to make sure you have proper infection control, and also patient rights issues. So those are some of the high-level conditions of participation you often see for different types of surveyed providers. If the provider or supplier has completed the enrollment form and met all of the conditions that apply to their particular type of provider or supplier, CMS will generally approve them to provide services and then receive payment for Medicare. If at any point, CMS does conduct surveys from time to time after your initial enrollment. So if CMS sometime decides that you haven't, a particular entity hasn't met the conditions of participation, or the terms of a provider agreement are no longer being met, they can revoke or suspend the provider or supplier's enrollment. And if you're already in operations and you have a relatively high Medicare payer mix, that can be extremely problematic. So that's why compliance with these enrollment requirements is really, really important. Okay, and then the third requirement here is that you have a covered service. And we're going to go into a lot of detail about the individual services within all the Part A, B, C, and D. But if we have a Medicare beneficiary and a properly enrolled provider or supplier, then the next requirement is that it's generally a covered service. And the baseline for a covered service is that it's reasonable and necessary. If the particular item or service isn't medically necessary, there's no coverage for it and no payment. Beyond that, to figure out if you have a covered item or service, it has to fit into what are called Medicare benefit categories. The statute outlines a number of benefit categories. And when we've done webinars in the past on how to conduct Medicare research, this is our starting point for most questions. What is the statutory benefit category for the item or service you're talking about? And it's important to know that because the benefit category is often tied to the very specific coverage and payment rules that apply to a service. So it's important that you going into it where you fit for coverage purposes in the benefit categories. This slide provides just a high-level overview of some of the common benefit categories. These are all found in the statute, and we have all the statutory sites here if you want to go look them up. But certainly not comprehensive here. But these are the most common. We've got inpatient hospital services, physician services, Incident 2 services, which we'll talk about a little bit later, includes Part B drugs in some cases. Diagnostic services, therapy, durable medical equipment, home health, hospice, etc. And just as the statute outlines the benefit categories and what is covered, it also outlines a number of items and services that are never covered by Medicare. So this list here is also not comprehensive, but these are the things that come up most frequently. Medicare does not pay for hearing aids, eyeglasses, contact lenses, dental services, personal comfort items, cosmetic surgery, and the list goes on. One topic, this is sort of an ancillary topic here on our covered service overview, but we wanted to address the concept of advanced beneficiary notices, or ABNs, which it comes up with some frequency when you talk about whether or not a particular service is covered, and then ultimately, if it's not covered, can a provider or supplier bill the beneficiary for that non-covered service? So it's basically a notice to the patient that Medicare is not likely to pay for the item or service because it's not covered, and that the patient is likely to be held financially responsible. And the reason for the lack of coverage determines whether or not a provider or supplier is required to issue the ABN. So for example, an ABN is mandatory when the service is one that may typically be covered by Medicare, for example, a routine lab test, but it's not covered here because Medicare doesn't consider it medically necessary for that patient in those circumstances. If a provider or supplier fails to issue the ABN in that instance, it can't bill the patient if and when Medicare doesn't ultimately cover that service. So, and by contrast, an ABN is not required when the service is on the list of non-covered items. So, if it's never covered by Medicare, then you don't need an ABN, and you can go ahead and bill the patient and recover your payment that way. Okay, so our final requirement to get to payment here, if we have coverage for the item or service, meaning it fits in a benefit category, then the last step is confirming that all of the relevant Medicare conditions of payment are met. These rules that define, not only the payment methodology, but also the additional prerequisites to payment. Most conditions of payment are service specific. So, for example, a hospital inpatient admission, in order for that to be paid, the hospital has to have an admission order from a qualified practitioner. And then we have, other payment rules that are more general or administrative in nature. And we won't go into the details here, but some examples of those are things like having a certification for the service or an assignment, proper assignment and reassignment of the claim. Okay, so just to recap, the results of having an eligible and entitled beneficiary, a properly enrolled provider or supplier, a covered service, and meeting all of the payment conditions ultimately leads to Medicare payment being allowed. And this leads us to a more thorough discussion of the individual types of services and coverage under A, B, C, and D, and how Medicare pays for them. So I'm going to hand it back over to Brad to discuss.
Great, thank you, Sarah. So as Sarah discussed, and Sarah, if you want to jump to the next slide. As Sarah discussed, Part A covers inpatient hospital services, SNF services, home health services, and hospice services. Some of these providers, particularly hospitals, bill all of the parts essentially. So the reason that it's important to sort of break this down by whether or not you're billing Part A, Part B, Part C, or Part D is because the payment rules are different in each. So we want to make sure that we go through how each is paid. Next slide. So under Part A, the inpatient hospital services and supplies, this includes general and acute care hospitals. So these are community hospitals and also specialty hospitals such as orthopedic hospitals, surgery hospitals, cardiac hospitals. And in each inpatient hospital stay, the beneficiary is limited to 90 days per spell of illness. And the spell of illness starts with the inpatient admission. So if a patient comes in through the emergency room and then is under observation for some time, those days don't count. It only counts once they've made a determination, a physician has made a determination that the patient needs to be hospitalized on an inpatient basis and writes the admissions order. To the extent that they need more than 90 days for their spell of illness, beneficiaries also have 60 lifetime reserve days that they can draw from. And then per spell of illness, there is also 100 days of extended care per spell of illness. So that would include long-term care and rehab. Beneficiaries pay deductible for their inpatient stays. They're no deductible for 1 through 60. Days 61 through 90 and 91 through 150, there are escalating deductible amounts that they're responsible to pay. And other hospitals furnish inpatient services as well. They are paid on a separate basis. Most of them have their own prospective payment system, which we'll discuss in a moment, but these are long-term care hospitals, critical access hospitals, psych hospitals, rehab hospitals, and children's hospitals. Skilled nursing facility services. So this is post-acute care. So you can go into a skilled nursing facility if you need skilled nursing. This is not custodial care. It's not basic assisted living or basic nursing facility, but you need skilled nursing care, some rehab, and supplies. As I mentioned, you get 100 days per spell of illness for a SNF stay. And you are required to have a hospital stay of at least 3 consecutive calendar days prior to the SNF admission. So if you go in through the emergency department, again, and have, you're assessed in the emergency department and then you spend some time in observation, you don't get to go straight to the skilled nursing facility. You would require, in order to get that coverage to kick in, you would need that 3-day stay in the hospital prior to admission. That rule can be waived under certain circumstances that we'll talk about later for certain new payment models that they have coming up. So participation in certain accountable care organizations, for instance, would allow you to waive that rule. And you need to be admitted to the SNF within 30 days after that discharge. So you might not know that you need SNF care right away, so you go home and then realize quickly that you indeed need skilled nursing care. The physician can admit you to the SNF within 30 days. And medical necessity certification and recertification is required in the SNF setting. So this is a requirement in a lot of these care settings that the physician reassess the patient with some regularity to ensure that they're in the right level of care, they still need that level of care, and that they're just in the right place. So that happens in a lot of different settings. Similar to the hospital, skilled nursing facilities are paid under a prospective payment system, and that's specific to skilled nursing care. Next slide. Part A also covers home health services. This is the intermittent nursing and therapy services and supplies that's provided to a beneficiary in their home. These are only for patients that are confined to their home or another outpatient setting, and that they are receiving care from a physician who's established a plan of care that requires home health. That because you either need intermittent skilled nursing care, physical therapy, speech language, or continuing OT. Now, home health is covered under both Part A and Part B. So when you're talking about home health, you have to figure out if the patient has both or just Part B, or just Part A. Part A will cover the first 100 days of home health visits if the beneficiary had a 3-day or longer stay in a hospital or SNF and was discharged from that stay within 14 days of the first home health visit. And then Part B will cover after 100 days, or if the Part A criteria is not met. And if you only have one or the other, then you get coverage under just that part. Home health also has a prospective payment system that is specific to home health services. Next slide. Hospice services are those services provided to the terminally ill. If a patient signs an election form that says that they want to elect hospice care, in doing so, the patient relinquishes right to Medicare payment related to the treatment of that terminal illness. So if you have cancer and you're not expected to survive that, when you go into hospice, you would stop getting chemotherapy, for instance, but you would still get comfort care and the like, and you can get treatment for conditions that are unrelated to the terminal condition. The physician must also sign a determination that the beneficiary is terminally ill and the prognosis of that terminal illness is less than 6 months. There must be an established plan of care, and there are several different benefit periods for this. So you get 2 90-day periods and then unlimited 60-day periods after that. And this, again, is for to give an opportunity for physicians and the hospice to have a face-to-face encounter with the patient, reassess, and recertify the need for hospice care, or whether or not they want to relinquish hospice care and go back to straight Part A services and treatment services. Hospice includes nursing care, social services, physician services, counseling. You can get a home health aid, appliances and supplies, drugs and biologicals, and therapy services. Hospice providers are paid a daily rate per patient, regardless of the amount of services performed in a day. So there's some days that you will come out ahead on that, and some days that you'll be behind. But hopefully, on average, you're paid appropriately for that care. Next slide. So I wanted to go a little bit more in depth about what a prospective payment system is, and I'm going to do so with the hospital inpatient PPS example, although, as I mentioned, a number of other Part A services are covered under a prospective payment system. But under the prospective payment system, or PPS, services are paid a predetermined flat amount. We typically call this a bundled payment amount. And in the hospital inpatient setting, it's based on the beneficiary's diagnosis, which CMS yearly sets a rate that represents the average national cost to treat a beneficiary with that same diagnosis. And you will get paid the PPS amount, and we'll go over sort of how they calculate it, but you get paid that same amount regardless of the cost of stay, regardless of the number of services you provide. And so on any given DRG or any given diagnosis, a hospital can win or lose. So it does incentivize hospitals to be efficient with their care and try to collaborate to some extent with various providers to bring down the cost while increasing quality. Hospitals are also paid for various quality measures that I'm going to talk about in more detail in a moment, value-based purchasing standards, hospital readmissions, and hospital-acquired conditions. And then there are certain limited costs and adjustments that are still based on reasonable cost principles, but not many. Next slide. So this is a fairly oversimplified chart about how CMS would determine a payment for a beneficiary for an inpatient hospital stay. We've sort of boiled it down to 5, but there are a couple of charts on the CMS webpage that I thought about including in here that show you that it's much more complicated than it looks here. But essentially, the hospital will submit a bill to their Medicare Administrative Contractor, or their MAC, for each patient it treats. And on that claim will have a diagnosis code or a series of diagnosis codes, and the MAC will categorize that case into a DRG to establish what DRG they're under. The base payment rate, or the standardized amount, is the is not DRG specific, but it's adjusted by wage index to reflect the area that you're in and the cost of labor. That adjustment is made, and then the standardized amount is multiplied by a relative weight for that DRG. And then you get the adjustments after that. So the additional amounts will be added to the payment for hospitals that engage in teaching, medical residents, hospitals that treat a disproportionate share of low-income patients, which includes sort of the incurring costs of uncompensated care, cases that involve certain approved new technologies, and high-cost outlier cases. And then, as I mentioned before, and as we'll go into more detail in a moment, if applicable, they'll make adjustments to that payment for the quality programs, the value-based purchasing, and the like that we'll talk about in just a moment. So there still are, while in a great majority of the cases we have moved from cost-based reimbursement to prospective payment systems that aren't directly related to costs, there still are some vestiges of cost reimbursement. And under Part A, we see this with rural hospitals, so community hospitals, critical access hospitals, rural referral centers, Medicare-dependent hospitals, and then there are certain hospitals that are excluded from IPPS. Children's hospitals, cancer hospitals are examples, also psychiatric hospitals and long-term care hospitals. And some of the graduate medical education adjustments are based on costs as well. Blood clotting factor, bad debt for hospitals. So this is an amount that hospitals can claim on their cost reports annually. And hospitals can capture 65% of their bad debts that are attributable to non-payment of Medicare coinsurance or deductible after reasonable collections are made. So if you get your primary payment for Medicare and then you're billing the patient for their deductible and coinsurance amounts, but you're not able to collect that amount, Medicare can reimburse you for some of those costs, as well as nursing education and organ acquisition costs. All of those still have some basis in cost reimbursement, and those costs are captured as part of your cost report that's billed annually. And we will go into cost reporting in more detail on one of the later boot camp seminars, so hopefully you'll be able to join that as well. So originally, quality was not a factor in Medicare reimbursement. When we were talking, even before we were doing prospective payment systems where hospitals and other providers were paid on the basis of just cost, nobody was talking about quality. You got paid for the volume of services that you provided, and then the CMS program woke up and said, well, this doesn't make much sense. We're incentivizing volume. We're incentivizing people doing more and more services, so we're going to change from cost-based payment systems to prospective payment systems, and we're going to look at quality because we want our providers within the Medicare program to provide the most efficient care but also the highest quality care. And so starting in around 2002, CMS announced a collaboration with a variety of organizations to start to get some public reporting of hospital data. And that was a voluntary initiative around 10 measures around heart attacks and pneumonia, for example. And we have come a long way since. So if you go to the next slide, quality is becoming increasingly important for hospital inpatients. And there's a lot of money on the line here, so it's important for hospitals to pay attention to these programs. So the Hospital Acquired Condition Reduction Program is an incentive for hospitals to reduce hospital-acquired conditions, and then the worst performing quartile receives a 1% negative payment adjustment. So you want to stay out of that worst performing quartile. The Hospital Readmission Reduction Program requires a reduction to the hospital's base operating DRG payment amount to account for excessive readmissions. So they don't want you discharging a patient because you're coming up on the amount where the DRG payment doesn't make any sense for you, so you're going to discharge. Well, you're going to take a penalty if that patient needs to be readmitted because they weren't supposed to be discharged in the first place. This reduction is based on a 3-year risk-adjusted readmission rate for just a few conditions: acute myocardial infarction, heart failure, pneumonia, COPD, and total hip, knee arthroplasty, and coronary artery bypass. The value-based purchasing program is a payment adjustment to hospitals for inpatient services based on a set of core measures that are adjusted annually. So every year we get a list of what their value-based purchasing measures are. And for instance, fiscal year 2017, it was a 2% adjustment, which is an incentive payment that could get up to, across the system, about $1.8 billion. So a lot of money on the line there. And then the Hospital Inpatient Quality Reporting Program is a program that requires hospitals just to report data on CMS selected measures. And you have to report this data in order to get the full annual increase in your payment. So we get a payment rule every single year with respect to the IPPS program. There typically is an increase in the base payment rate. And if you don't report these measures, you are going to be reduced to 1/4 of the applicable percentage of increase. So, and this program is not based on how well you do, it's just based on the reporting of it. So CMS can use those measures to come up with later quality programs. Value-based programs, those quality-based programs, are also in place for ESRD facilities, SNFs, and home health programs as well. And with that, I will turn it back over to Sarah to talk about Part B.
Okay, so yeah, Brad went over what's covered under Part A. And when we talk about Part B services, it's an incredibly broad group of items and services. And it's a lot of more, we can talk about Part A, it's a lot of institutional entities like hospitals and skilled nursing facilities and all the services that they provide in a, a relatively, a bundled fashion. But Part B is got a lot of different parts to it and, individual services that are paid differently. So I'm going to talk first about what's covered and then go into a little more detail about how they're paid for. We've grouped a lot of these, the Part B services, into what we're calling professional services here. Your typical physician office services. So, you go to your physician office and you receive care from a physician or a non-physician practitioner like an advanced practice nurse or a physician assistant. But these, professional services can also include, therapeutic radiology services, physical, occupational speech therapy, the professional component of diagnostic tests. So that's, the physician's part in reading the results of a diagnostic test. And you also have a Part B benefit category for what are called Incident to services. And it's just sort of a tricky name, but the concept is pretty straightforward. These are services that are furnished incident to the service of a billing physician or practitioner. So for example, when you go to your doctor's office, oftentimes you're seen by, a registered nurse. And registered nurses for Medicare purposes aren't authorized to bill Medicare independently, and they don't enroll in Medicare and bill independently. So, that registered nurse might perform a service in the physician office, and as long as the physician is properly supervising and certain other particular conditions of payment are met, the physician can bill for the service that the RN provides as an incident to service under the physician's name and receive full payment under the fee schedule for that service as if the physician performed it. So it's an interesting benefit category. It comes up a lot as you talk about professional Part B professional services. The benefit category can also, incident to benefit category can also encompass drugs, and I'll get into that a bit later. So that's one large category of Part B. Probably the other largest category is hospital outpatient department services, and these are items and services that are furnished in a hospital outpatient department, and that's a pretty specific definition. And it can include, things like emergency room services, same-day surgeries, X-rays, radiology services, medical supplies. When they're performed in a hospital outpatient department, they become hospital outpatient department services. So to focus here on what is a hospital outpatient department, because really the location a lot of times defines the service in this case. Hospital outpatient departments can be either on campus of the hospital, meaning typically within 250 yards from the main hospital, or they can be off campus. In either case, though, the rules differ slightly based on whether it's on or off campus, but they have to meet, regardless of where it's located, they have to meet what are called the provider-based rules, which is something that's been in the news a lot recently. But the provider-based rules essentially require the hospital outpatient department to be sufficiently integrated with the main hospital. And that means that the department operates under the main hospital's license, if that's allowed under state law, that the hospital outpatient department is held out as part of the main provider, and it's both clinically and financially integrated with the main provider. And when I say held out as part of the main provider, that means a lot of times you might have a physician office if it's off campus. It might otherwise say the physician office of Dr. Smith. And in this case, if it's going to operate as a hospital outpatient department, it has to be have the signage of the hospital. It has to appear and be clear to anybody walking into it that it's a hospital space. So overall, a hospital outpatient department has to act like part and parcel of the main hospital. And you might be wondering why why CMS went through all the trouble to make up these rules and to have specific rules that a hospital outpatient department has to meet. And the reason is that hospitals generally receive higher payment for services furnished in an outpatient department as opposed to a freestanding clinic, even if that clinic's hospital owned. So if the hospital has to jump through some extra hoops to prove that the service has been furnished in hospital space if it wants that payment premium. Within the last couple of years, CMS has scaled that back a little bit, and they've eliminated the payment differential for new off-campus hospital outpatient departments. So they, again, this is one scenario where CMS kind of stepped back and wised up and said, hey, why are we paying a different rate for what feels like the same service? If it's furnished in a physician office, a freestanding physician office, versus a hospital outpatient department. So for new off-campus outpatient departments that come online now, there's no payment differential, but there is still for any historic, pre-existing hospital outpatient departments, that differential still exists. Part B also includes durable medical equipment and prosthetics, orthotics, and supplies, or DME POS, often referred to just in shorthand as DME, although it's a little bit, don't like to leave out the prosthetics, orthotics, and supplies, but most commonly we think of DME like wheelchairs and CPAP devices, other home oxygen equipment. It can also include drugs that are used in conjunction with DME, so if a drug's infused through a pump, the pump is the DME and the drug is considered a supply under this benefit. But we also have the prostheses and the orthotics, so artificial limbs and things of that nature. The key coverage criteria for DME and prosthetics, orthotics, and supplies is that they have to be used in the home. So when an item is covered as DME and under the DME benefit, it's when a patient's at home. And it frequently might follow a hospital discharge. So, for example, a patient has a hip replacement and they need to be discharged home with a wheelchair, or if it's a broken bone, a broken leg, they might be discharged home with crutches. And so the DME is then used primarily at home. Part B also covers diagnostic services. So this is a large category, includes things like x-rays, EKGs, MRIs, mammograms. There are typically two parts to a diagnostic service. You have the professional piece of it. That's the physician or another practitioner interprets the test results. And actually that piece of it, for following my categorization of Part B services here, that piece of it goes back into the professional services component, so because it's the professional side of the diagnostic test. But you also have the technical component, and that's basically the test itself. So the cost of the equipment and perhaps the technician and whatever supplies that are needed to perform the diagnostic test go into payment for that Part B technical component. These tests are sometimes, they're performed in freestanding clinics like independent diagnostic testing facilities, or IDTFs, sometimes performed in physician offices. But and you might be wondering at this point, there's some overlap here in what I've talked about. I was talking about Part B, hospital outpatient department services, and that can include diagnostic tests. And then we have this separate diagnostic services performed in a freestanding setting. Just keep in mind that if a diagnostic test is performed in a hospital outpatient department, then the technical component of that test then becomes a hospital outpatient service as opposed to a freestanding diagnostic test. That might be a little complex here, but that's important because the rules are different for a hospital outpatient service versus a freestanding diagnostic test, and the benefit categories are different. So that's why I draw that distinction there for you. Oh, I wanted to also mention there that there are supervision, specific rules about supervision, and there are 3 levels of supervision generally, and they have to be met in order to get paid. So the physician supervision requirements are generally conditions of payment, and we mention it specifically here because it's something that's frequently, there are mishaps in providing appropriate supervision, and people get caught in audits with some frequency for lacking appropriate supervision. Part B also includes services furnished in ambulatory surgery centers, or ASCs. They furnish outpatient surgical procedures, meaning that they limit their services to surgical procedures that don't require an overnight stay. And they typically operate independently from hospitals or physician offices, and they're subject to their own enrollment requirements, their own payment methodology, although they can be located in the same building or adjacent building as long as they maintain their own distinct space. Part B also covers certain drugs. I spoke earlier about drugs covered as under the DME POS benefit when they're furnished using an item of durable medical equipment like an infusion pump. So that's one way that Medicare covers drugs under Part B. But the other ways there are 2 other ways. The first one here is that under the Incident to benefit. And we talked about earlier that physicians sometimes provide services with the assistance of nurses, and those professional services performed by the nurse are billed incident to the service rendered by the physician. Well, drugs can be billed in a similar way. When drugs are furnished in a physician office, for example, they're billed as a supply that's furnished incident to the physician's professional service. So a physician might provide a visit. They might sit down with you and take your history and talk to you a bit, and then prescribe a drug. And if it's administered in the physician office, not usually self-administered, it has to be something that needs to be administered in the physician office, then they can bill that as a supply that's furnished incident to their service. The Medicare statute also provides coverage for a number of drugs under their own benefit categories, so that includes certain vaccines, oral chemotherapy drugs, blood clotting factors, immunosuppressive drugs. Those all have their own benefit categories. And keep in mind for drugs, if Part B doesn't cover a drug because it's not furnished in the right setting, or some other aspect of the Part B coverage criteria are not met, it might be covered under Part B. So sometimes the coverage can cross over to Part D. So this is what I was talking about earlier with Part B covering a whole host of services and types of suppliers. So it's really a laundry list. This slide really is a catch-all for all the other Part B services that we don't have time to discuss in a lot of detail, but it captures both the services like lab services and dialysis services, as well as Part B supplier types. So anytime you see any of these services or supplier types, then we're operating under Part B. I want to now go into some more detail about the Part B payment methodologies, and just like there are a number of different benefit categories and types of services under Part B, there are a number of payment methodologies as well. Many suppliers are paid under a fee schedule, which is essentially a payment for individual services or item. It's a per service or per item payment, and that includes professional services of physicians and non-physician practitioners, DME items are paid on a fee schedule, as are clinical labs. And if you're familiar at all, the clinical lab fee schedule is undergoing a fairly significant overhaul right now, this year and next. But Part B also has prospective payment models, like Bragg mentioned. So hospital outpatient services are paid on a prospective payment system, ASCs as well, and ESRD dialysis services. And then, there are some other different kinds of payment methodologies. So rural health clinics, for example, are paid in all-inclusive per visit rate. I'm going to go into more detail about some of these here in a minute. And in the interest of time, I think we're just going to talk today about a couple different specific payment methodologies. The first one here is the physician fee schedule. Again, this pays for the individual professional services of physicians and non-physician practitioners. Each professional service is assigned a code that describes the type of service provided, and you'll hear people refer to those as HCPCS codes or CPT codes. And Medicare has actually assigned a payment rate to each of those codes under the fee schedule. If a physician provides an initial office visit, there's a code assigned to that, and there's actually, if you go to the Medicare website, there's actually a physician fee schedule lookup tool, and you can go and enter the code and see the reimbursement amount for that particular service. And the payment rates, the actual payment rates on the fee schedule, are derived from what are referred to as RVUs, relative value units, and those take into consideration the amount of work and the overhead expenses that Medicare expects to go into that service. Under the physician fee schedule, when physicians bill directly for their services, they receive 100% of the fee schedule. 80% of that amount comes directly from Medicare, and 20% comes from the beneficiary through copays. And other practitioner types that are non-physician practitioners who are authorized to enroll and bill Medicare directly. So that's a limited category of non-physician practitioners who are authorized to do that. It includes nurse practitioners, physician assistants, clinical nurse specialists, and maybe one or two others. But when they enroll and bill directly, they're paid a lower rate. For a nurse practitioner, for example, it's 85% of the physician fee schedule. So they get 85% of the total amount, and then 20% of that 85 comes from the beneficiary, and the rest comes from Medicare. I also wanted to as Bragg talked about the prospective payment systems, the fee schedule is also affected by certain other factors, and the amount you get can be adjusted based on other factors. You'll hear people talk about what's called the site of service differential in physician payment, and this is kind of the reverse of what I was talking about with the hospital provider-based payment, which is when they get paid more when services are performed in a hospital outpatient department. In this case, the concept is that physicians are paid slightly more under the fee schedule when they furnish services in their own offices versus when they're furnished in an institutional setting like a hospital. So again, it's a little bit the reverse, and the reason for that is the overhead expense. When they're furnishing services in their own physician clinic, the assumption is that the physician is bearing the brunt of the overhead expense, and they're entitled to additional payment for that, whereas when a physician furnishes services in a hospital, the hospital pays for those overhead services. And there are other adjustments too, including geographic adjustments and then certain payment adjustments. And under MACRA, Bragg is going to talk about that in a little bit. Okay, so I wanted to also move on and talk a bit about the hospital outpatient prospective payment system. Under this method, it's a similar in the bundled payment in the sense of the hospital inpatient, but it's structured in a little bit of a different way. Services furnished in the hospital are classified into what are called ambulatory payment classifications, or APCs. So services that are similar in their clinical intensity and resource utilization and their underlying cost are all assigned the same APC. So if particular surgeries are all similar in their clinical intensity, they would get assigned to the same APC, and there's a prospective payment rate tied to that APC. And it's a bundled rate, and it includes payment not only for that underlying surgery or service, the primary service, but any supplies and ancillary, I would say most ancillary services that go into providing it. So, like I said, in some ways it operates similar to the inpatient PPS, although the outpatient rate is tied to the service furnished in the APC that it falls into rather than the diagnosis code. And so this is just another summary of what I mentioned at the beginning, which is, there are many payment methodologies under Part B. Again, ESRD facilities have a case mix adjusted prospective payment system. ASCs have their own PPS-based system that's based on the hospital outpatient PPS, and it's a variation of that and an adjustment for the ASC setting. DME and POS, the prospective orthotics supplies, are paid on a fee schedule, although there's some competitive bidding for certain product classes, so that means only certain providers or certain suppliers can furnish those services. Ambulance services have a unique national fee schedule with local adjustments, and then rural health clinics and drugs are also paid on their own distinct payment methodologies. And with that, I will hand it back to Greg to talk about Part C.
Great, thanks, Sarah. So everybody can take a breath. We're through the two big ones. Part C is, if you want to go to the next slide, is what commonly referred to as Medicare Advantage, and this is where CMS contracts with private payers to cover Medicare benefits. And Medicare beneficiaries can voluntarily enroll, so if they have a specific condition, for instance, they might go into a Medicare Advantage plan that has benefits, above and beyond Medicare benefits for that particular condition. And then the CMS pays the plan a monthly premium or a per patient per month payment, and then the plan manages that patient's care. And beneficiaries also have the option to go into a Part C and Part D program. It's called the MAPD program, which would cover their drug costs as well as their Medicare Part A and Part B benefits as well. So plans must cover all of the Part A and Part B services. They can provide more than that, and they have to follow the national coverage determinations and local coverage determinations of Medicare and other coverage guidelines, but they can also have their own rules. So, for instance, when we're looking at a billing problem that arises in certain situations, we can look at Medicare, original Medicare, differently than we look at Medicare Advantage, depending on depending on the plan. And the plan can design its own cost-sharing obligations, can do a lot. It has a lot of flexibility within the CMS guidelines to create their own plan in order to manage costs. Go to the next slide. And in general, the obligations of the plan and the provider are based on contracts between those two. So when you have original Medicare, you go to a physician who's enrolled in Medicare, and they just have to follow all of the Medicare rules, payment rules, and coverage rules that we've talked about, bill their Medicare administrative contractor, and the provider gets payment. How a provider is paid in the Medicare Advantage context depends on their negotiations with the plan. So plans have to pay at least the Medicare rate, but they can pay something different. They can pay more, if they need certain physicians or certain types of suppliers or providers in a particular area, they may be willing to negotiate for a higher payment rate than you might get from Medicare. So it just depends on the specialty, what type of practitioner or supplier you are, where you're located, that type of thing. But in all cases, the intent of the Medicare Advantage plan is to decrease costs and increase quality, which we will talk about more as well in the various ways that Medicare and Medicare Advantage are moving more towards quality payments. In very brief overview, and I'm going to go over to Sarah for Part D.
Yep, okay, so Part D is very similar in a lot of ways to Part C. The benefits are obviously very different, but it's structured and the way it operates is sort of similar. So the Part D, unlike Part C, Part D is effectively in addition to Parts A and B. It's not an alternative or a replacement for them like Part C or Medicare Advantage plans are, but it provides additional coverage for drugs that are not otherwise covered under Part A and B. And oftentimes, I think I mentioned this at the outset, the plans are, could be purchased as part of a Medicare Advantage prescription drug plan. Bragg mentioned MAPD plans where both C and D are together, but it can also be purchased independently as a standalone to go with original Part A and B Medicare. So it's voluntary, and there are typically additional premiums associated with these plans. The services covered under Part D, it depends on the plan. They have to meet, what is covered has to meet certain baseline requirements, has to be FDA approved, and has to there has to be a prescription, has to be on-label use of the drug in order to have coverage. And as I mentioned, they have to be drugs that are not otherwise covered under Parts A and B. Beneficiaries can buy into better plans with lower deductibles or more coverage. For example, you probably have heard of what's called the donut hole. You can pay more to avoid the donut hole, or the coverage gap that occurs once a patient hits a certain amount in drug costs for the year. They go into a coverage gap, and that exists until you reach catastrophic drug coverage. The Affordable Care Act does, when it went into place, it did put in a provision that provides discounts for drugs purchased while you're in the donut hole. And the ACA, Affordable Care Act, ultimately does repeal the donut hole effective 2020, so that coverage gap should go away. We have heard in Washington talk of repealing the Affordable Care Act, so that's one thing that would potentially go away if the Affordable Care Act is fully repealed. And as far as payment under Part D, as with Part C, the Part D plans negotiate directly with the contracted pharmacies. So the payment terms are not generally known to us, but they're the product of commercial negotiations between the plan and the contracted pharmacies. And there's actually a statute in place that's called the non-interference clause of the Medicare statute that prohibits Medicare from interfering with payment negotiations between Part D plans and pharmacies. So there's been some talk of amending that provision to help have the government interfere, in other words, to bring down drug costs, but that hasn't happened yet. So for the time being, it's strictly based on commercial negotiations, as with Part C. And I will flip it back to Bragg to talk about what's next on the Medicare horizon.
Great. We're going to pause on the slide for just a minute because I kind of want to level set as we go into some of these new initiatives that CMS is looking into. And as we've talked about repeatedly throughout the presentation, we're seeing a move from, we went from cost to prospective payment systems, and now we're putting quality into those payment programs. And these payment programs are really evolving. Some of them are in place but will evolve over the next few years. Some of them are changing every year. There is a center within CMS that is specifically supposed to drive innovation. And how do we create new payment models that really focus on the efficiency of the care and the cost of the care and the quality of care. So what we're talking about are really 4 different payment models. We've got the fee-for-service that we've talked about, where there's no link to quality. It's 100% volume-based. If you perform a service, you get paid for it. We have a fee-for-service with some link to quality. This is sort of the data metrics that we talk about related to quality and the sort of incentive payments or payment reductions based on that quality. And then we have some advanced payment models that use the fee-for-service architecture but create some incentives for providers to better coordinate with each other. So hospitals, physicians, long-term care providers, SNFs, and the like to get together and say, how do we coordinate this patient's care so that we can have the best quality for the lowest cost? And for certain groups of organizations like that, we call them accountable care organizations. So those are organizations where people have gone out and contracted with each other. So you've got the hospital, the SNF, physician groups, and the like, contracting with each other to say we think we can do this for less money and to have a better quality of care. Those are called accountable care organizations. And if they're successful in that, each of them still gets paid under their respective payment systems. But if they're able to reduce the cost and the efficiency of care, they're able to share in some of those savings. So Medicare will give them some money back that they can share. And then we go into, as a fourth model, and this is one of the ones that we're going to talk about here in a second, are population-based models, where providers in those ACOs are not getting paid under their respective payment systems, but rather they're taking risks. So they're getting a per-patient payment, and it's up to them to allocate it. Usually the hospital, up to them to allocate it between the various care providers, and that puts them directly on the hook to make sure that they're managing their population in the most efficient and most quality-driven way. And so with that, we'll go to the next slide. And one of the big initiatives in this respect is MACRA, which is the Medicare Access and CHIP Reauthorization Act of 2015. This was a bipartisan effort that was enacted in April 16th of 2015. You heard me right, it was in fact bipartisan. Which is obviously one of the very few bipartisan healthcare efforts that we have had in recent years. And what MACRA did was it establishes the CMS Quality Payment Program, which rewards value and outcomes. And there are two different pathways under this program that we're going to talk about: the MIPS system that you'll hear, Merit-Based Incentive Payment System, and the Advanced Alternative Payment Models, or APMs. We got final rules for this for the first round of this program in November of 2016. Similar to other payment programs, so we would expect to see an annual update to this program. We have proposed rules for next year that we expect to be finalized in November. Part of the goal of the program, this is really focused largely on physician payment and practitioner payment. So as we talked about, they want to improve care, have better outcomes, decrease the burden on providers, and preserve their independent practices. But they also want to encourage alternative payment models that align incentives across the various stakeholders and advance the delivery system reform by unifying the legacy programs. And by that we mean bringing all of the fee-for-service programs into these advanced delivery systems, and it's really changing the way we think about healthcare, how healthcare is delivered and how it is paid for. And some of the major changes it made was to repeal the sustainable growth rate. This was an annual effort with Congress because the physicians were about to take a very significant pay cut. And so every year there was wrangling in Congress about continuing on the sustainable growth rate, and finally this program got rid of it entirely. Consolidating some of the Medicare quality programs that physicians were participating in, and applying some of those value-based payments to traditional Medicare fee-for-service, and aligning with commercial and Medicaid programs, and eventually migrating to risk, that fourth model we talked about. Go to the next slide. So this is a timeline. I'm not going to go into this in any significant detail. I just wanted you to have, after we discuss this, if you end up downloading the presentation, you can see the timeline of these various programs. And as you'll see at the top, the Medicare fee schedule updates will start to go away over time, and in 2020 we won't get updates on that anymore. You'll instead see a movement towards MIPS and APMs, which will drive your payment amount. Next slide. So I'm going to start with MIPS. And so MIPS is the default payment system for eligible clinicians. So physicians, PAs, NPs, CNSs, CRNAs, and including any clinicians that bill Part B. It has some exclusions, and others can be added in 2021. We're still waiting for those. So some of the exclusions relate to low volume threshold clinicians and clinicians who are not patient-facing, newly enrolled clinicians who are just getting out of residency and have no idea what MIPS is and how to participate in it. And if you participate in one of the advanced payment models, you don't have to participate in the MIPS program. Next slide. So a lot of this is data-driven. So this is just a chart about how we report data. If you're not an eligible physician, you can voluntarily report quality data in order to gain experience with the MIPS program, but you don't have to. If you are an eligible clinician, either on an individual or group basis, there are various ways that you can report your data, And if you're in an APM, there'll be APM-specific reporting requirements that vary depending on or how you report it depends on the year. Next slide. So in the MIPS program, they are taking the fee-for-service payment and adjusting it based on a performance score, which is linked to 4 measures: quality, advancing care, information, clinical improvement, and resource use. And based on your score across those factors, you get an adjustment annually. So for 2019, your fee-for-service payment can be adjusted either positively or negatively by 4%. And those weights will change annually and grow. So eventually we will be up to 9% in 2022. So there's a lot of money on the line to make sure that physicians are working on these metrics. Next slide. We got some relief in 2017, and after they sort of realized that we were going all in all at once, and there was the provider community or the physician community, excuse me, sort of raised their arms up, said we can't do this all at once. And so they allowed practitioners who were going to participate in the MIPS program rather than the APM program to kind of pick their pace. And so the minimum that they can do is you can report some data. If you report any data, some data, at least one quality measure, one improvement activity, or you meet some baseline ACI requirements, you're not going to get a penalty, but you're also not going to get an incentive. A partial, if you want to go in partially, you can report on at least 90 days of data for more than one measure, and you won't get a penalty, and you'll get a potential incentive. So the more you report, the more chance of an incentive you're going to get. That incentive is not guaranteed, but there's a possibility. And if you decide to dive in all at once, you are reporting data on at least 90 days of 6 quality measures, including 1 outcome measure, high and medium weight improvement activity, and base ACI plus additional measures, which we're not going to go into in much detail, but across the various measures, you're reporting it for the full time period required, and this gives you the maximum opportunity to receive incentive payments. If you fail to report even one, then you're going to take a 4% hit in 2019 on your payment. So we really encourage providers to at least get that one measure reported. Okay, so if you decide not to participate in the MIPS program, and again, the MIPS program is the default program. If you don't participate in an advanced payment model, then you're going to get paid under MIPS. And so this is the movement towards risk-based payment, and which is going to tie the payment to patient outcomes and population health and episodes of care. And so in this advanced APM, the incentives are you get a lump sum 5% bonus for the base year for the professional services. You are exempt from the MIPS reporting and payment adjustments, although there still be quality reporting. And there's a higher Medicare fee schedule base rates beginning in 2026. So there are some good advantages to participating in an APM model. Some of the requirements, excuse me, on the next slide, in order to be in an APM, you have to use a certified EHR technology. You have to have your professional service payments linked to quality measures. The APM itself has to bear the financial risk or involve a medical home model. So we've talked about some of these, the MSSP or the Medicare Shared Savings, ACO. There are various tracks of that ACO model. So some of the more advanced tracks where they're actually taking on risk. So the hospital will get the money for the patient for an episode of care, and they'll have to distribute it amongst their ACO for whatever services they provide. And then they'll start to phase in other payers in 2021. And in order to participate also, you have to have a certain payment or patient count thresholds that are assigned every year, which are listed here. And again, as you'll see in 2021, all payer combination thresholds come into play. Next slide. So we also have a number of other models that they are playing with right now. So as I mentioned, there's the CMS Innovation Center, which is established as part of the Affordable Care Act. They're designed to test various payment models. This next discussion is about some of those tests that they're doing, and we've recently received an RFI from CMS for a redesign of the Innovation Center and the addition of new programs. Some of this is associated just with the administration change, but some of it is just to get ideas from the community about the various programs, what should we do, and because there are a lot of different programs and it's hard to keep it straight. Next slide, and I'm going to go through these pretty quickly because I want to save at least a few minutes for questions. But the first one is the Bundled Payment for Care Improvement Initiative. This began in 2013, and some of the components are still underway. But essentially, there are 4 broadly defined models which link payment for services received during an episode of care. Model 1 was paid for all DRGs, but the physician was still paid separately, and then there was a retroactive penalty or incentive payment. That ended in December of 2016. Models 2 and 3, the only difference between them is Model 2 has the inpatient stay included, and Model 3 does not, but otherwise would include post-acute care and readmissions. Both of those are on a retrospective basis, so Medicare makes everybody within that episode care their fee-for-service payments, and then they later reconcile those payments against the target price. And the providers and suppliers within the model will get either an additional payment or a recoupment request. And Model 4 is where we get to sort of full risk, where the hospital is paid for all of the Part A and Part B services during an initial inpatient stay and readmissions. And this would include the physician payments, and the hospital has to collaborate with the physician in order to decrease costs and increase quality. Next slide. We also have the Comprehensive Care for Joint Replacement Act. It's not an act, excuse me, initiative. And this began in April of 2016. It was originally mandated for hospitals in 67 geographic areas and was looking just at patients discharged with joint replacements. And right there, the knee replacements, it was supposed to expand to hip fractures in 2017. And again, similar to Model 4 we just talked about, or the other models we just talked about, the actual spending is compared to an episode target price. The hospital gets to recoup those savings and or repay costs in excess of the target. Next slide. There are various other episode payment models beginning in July 2017. They were originally mandated for hospitals in over 90 geographic areas for heart attacks, bypass-related procedures. Similar to the other models we're talking about, your actual spending is compared to a target price, and the hospital gets to recoup the savings and or repay costs in excess of the target. We're also moving into cardiac rehabilitation incentive model as well. You can move to the next slide. With the change in administration, we have those EPM and cardiac rehab incentives and the expansion to CJR to include hip fractures canceled in their entirety. So CJR will still have mandatory geographic regions, but they'll be reduced to 34 regions, and with the remaining areas being voluntary to participate. And in order to participate, the providers needed to make an opt-in in January of 2018. Will need to make an opt-in. So this proposes significant expansion of the voluntary programs in order to increase the number of programs that qualify as an advanced APM. I think it'll just take some time for this administration to get their arms around the various programs, what they want it to look like, how it coordinates with MACRA and some of the other quality initiatives they're going into. And so more to come on that. We also have Comprehensive Primary Care Plus initiative, which is a 5-year program in 20 regions, which is supposed to support patients with serious or chronic illnesses, provide greater access to care and health information, provide preventative care, engage families, and to better coordinate, and really trying to get the primary care model up and running again and getting those folks much more engaged in care of patients with those illnesses. Again, 2 tracks. You get a monthly management fee and also fee-for-service payments, or you can get a monthly management fee and a high rate of reduced fee-for-service payments and then additional primary care payments. They're also planning to have a role for state and commercial payers to support the use of these advanced primary care models. Medicaids have moved to this pretty significantly already, so I think this one is likely here to stay. And then the oncology care model is a 5-year program that'll go till June of 2021 with various performance accountability measures established for episodes of care around chemotherapy. About 192 practices applied and are participating in the program, and will include 14 commercial payers to provide broader incentives. So in addition to the standard fee-for-service payment, there's going to be a per beneficiary monthly payment and then performance-based payment per episode. So really easy stuff. So this is a very high-level summary. Like I said, we could talk for days on a variety of these issues, but wanted to just give you kind of a rough outline of what is out there both historically and where we're headed. And with that, and we only have a few minutes left, but we would be happy to take questions.
All right. Thank you, Brad and Sarah, for this educational collaboration. Before I take our first question, I would like to remind everyone just to type their questions into the chat and questions panel located to the right of your screen, and we'll take as many as time will allow. I will remind everyone, I did get a note about getting copies of the slides, so if you missed the intro, you don't have to wait. You can download those slides right now. Also, to the right of your screen, you'll see a handout section. Just expand that by clicking on the right facing arrow, and you will see a red PDF icon where you can download those right away. All right, so let's jump right on into our first question, which comes from Seth, and he is looking for a little clarification on ESRD facilities. Are they covered under Part A or Part B?
So that's a great question, and ESRD facilities sit sort of in the middle, unfortunately, just to make it even more clear. ESRD facilities are paid under Medicare Part B, but they are largely treated like a Medicare Part A provider, meaning that facilities have to go through survey and certification. They fill out the 855A application, and they have conditions of participation similar to hospitals and other providers, and so it's a little bit of both. But we generally think of them as Part A providers, although their payment is actually coming from Part B.
Gotcha. Thank you for that. Our next question is a little detailed, so let me just read it out. Comes from Roxanne. She says that we are having some difficulties with our Medicare Advantage plans. They sometimes follow Medicare guidelines, but they put their own guidelines along with it, but are more restrictive. Normally, these types of guidelines would be paid through Medicare. The Medicare Advantage plans are taking away what normally Medicare pays. Is this right?
So like I said, there is some flexibility with Medicare Advantage plans, but they should at least be following Medicare's NCDs and LCDs and other coverage rules. So they have to pay for at least what Medicare pays for. So if you are finding a Medicare Advantage plan that is more restrictive than straight Medicare fee-for-service, I would definitely appeal those claims. There's also, if you go on the cms.gov website, there is a Medicare Advantage section. There are people that you can contact at CMS that oversee those plans, and try it that way. And that's a slow-moving ship, of course, but there are ways. But I would appeal those claims if you're seeing them denied where Medicare would cover them.
All right, thank you for that. Sherry has our next question. She asks, what happens if a patient refuses to sign an ABN letter when it is required?
Sarah, you want to take that one?
Sure. I mean, so it's it puts the provider supplier in a very difficult spot if the individual declines to sign an ABN. And Brad, you can correct me if I'm wrong, but there may be a place to acknowledge that on the ABN that you've notified the patient and that they will be financially responsible. The assumption is that you're administering or giving the ABN to them before you give them the service. So before you furnish that item or service, and you're saying, here, we acknowledge that this is unlikely to be covered, and you are going to be financially responsible. And if they decline to sign it, you have the option not to provide it. But there may also be an ability to indicate on the ABN that you've been tried but unable to get the signature. I may be misremembering that though, Bragg.
Yeah, we can certainly go back and look. There are various scenarios that come up in ABN, and it depends on the coverage criteria that Medicare has. But if they refuse to sign, yeah, I mean, you can refuse to perform the service as well. I mean, because this is saying you don't have coverage for it. Do you want to pay? And if they don't, you don't have to provide the service. But you can also bill Medicare conditionally in that instance. But if you perform the service and bill Medicare conditionally and don't get paid, you could be stuck. So with the cost of that. So I would look at that closely if you have patients refusing to sign, and talk with either your compliance or legal departments around what to do in those instances. Nikki, are you still there?
Okay, I guess it helps if I take myself off mute. I think we have time for one more question, and this one will come from Stephanie, likely. She asks, when a patient comes in for a procedure such as foot care, can we charge for the professional component as well?
So I think, this is Sarah, this may depends a little bit on the setting that we're talking about. I don't know if for example, the foot care is being provided in a physician office, and what code or what particular service you're furnishing. If you're in a physician office, for example, the service that you're providing is likely a professional service, and it's there probably isn't a professional and technical component, as I was mentioning, for diagnostic services. So if you're in a physician clinic and providing some level of foot care, and it's an evaluation and management code, that's a professional service, and you can bill for that. If there is some type of procedure that has a professional and technical component to it, and again, I don't know what type of entity we're talking about, but if you're a facility and you're having a physician come in and help you, outside physician come in and help you provide that professional component, likely they are billing for the professional component. And if you have, if that physician is what's called properly reassigned their right to bill to you, then the facility can bill for the professional component. But again, I'm happy to take the question offline if there are more specific details about the setting and the type of service. But that's sort of the high level.
All right, thank you for that. So as we wrap up, I do want to take this time to thank our members and the healthcare community for joining our first installment of the Medicare Bootcamp series. As I mentioned, this is the first of 4 sessions. The next session is scheduled for October 24th, and the topic is Cost Report from Revenue Cycle Perspective. Obviously, there is a separate fee for this session, but again, it can be provided to an unlimited number of people within your organization. So to learn more and register for this and other upcoming events, feel free to visit hfma-co.org. One final note is you will be automatically routed to a survey at the end of today's webinar. So we'd love for you to share your thoughts, and be sure to provide the email addresses for everyone else in the room as well, so we will know exactly who participated in today's event. So thank you again to our guest presenters, Bragg and Sarah from Pulcinelli PC. We thank you, ladies, for sharing such great information, and wishing everyone having a great rest of your day. Thanks, everyone.